Welcome to this explainer. Today, we're going to approach cardiovascular anatomy exactly like a surgical team scrubbing into the OR. So, if you're an anatomy student in a CST surgical tech program, listen up, because this is literally made for you. We aren't just staring at flat, boring textbook diagrams today. No, we're going to explore the heart as a dynamic, living, mechanical pump. The exact same pump that you'll be actively working to repair, bypass, and handle throughout your entire career. Let's get into it.
Okay, picture this. Put yourself right at the operating table. The sternal saw has done its job, the retractors are perfectly in place, and you have to ask yourself, when that chest cavity finally opens, what exactly are we looking at? I mean, what's the actual spatial and functional reality of that organ beating right there in front of us?
Well, here's our surgical plan for today's explainer. We'll start with Section 1, the heart's surgical landscape. Then, Section 2, inside chambers and valves. Section 3, tracing the blood flow. Section 4 is all about coronary circulation and CABG. And finally, Section 5, the electrical conduction system.
All right, Section 1, the heart's surgical landscape, approaching the mediastinum.
So, before we make a single incision on the organ itself, we have to establish our spatial awareness, right? It's actually really fascinating how the heart rests right in the mediastinum. It sits securely sandwiched between the sternum in the front and the thoracic vertebrae in the back. It's roughly the size and shape of a closed fist, with its apex just resting right down there on the diaphragm. Now, this specific anatomical positioning perfectly explains why rhythmic compression during CPR actually works to maintain blood flow during cardiac arrest. You see, because the heart is literally trapped between those two hard, bony structures, compressing the sternum physically squeezes the heart. It basically acts as a manual pump, stepping in to save a life when the natural rhythm just fails.
Now, as we get a bit closer, we encounter the pericardium. Think of this as a tough, double-layered fibrous sac completely enclosing the heart. You've got an outer parietal layer and an inner visceral layer that tightly hugs the heart muscle itself. But as a future surgical tech, you absolutely must understand a critical, life-threatening condition here. It's called cardiac tamponade. If that pericardium becomes inflamed, or worse, if fluid or blood rapidly accumulates in the tiny, lubricated space between those two layers, it severely compresses the heart. The pressure is so immense that the heart physically cannot expand to fill with blood. It completely restricts its ability to beat, which, as you can guess, requires emergency surgical drainage.
Okay, let's move to Section 2, inside chambers and valves, the mechanical core.
Moving deeper into our surgical approach, let's go ahead and cut through that pericardium, look inside, and see how this builds our structural understanding. Internally, it's like a house divided into 4 distinct rooms. You have the 2 upper receiving chambers, the right and left atria, and the 2 lower discharging chambers, which are the powerful right and left ventricles. Take a look at those thick walls of cardiac muscle tissue. That is the myocardium, and it is doing all the heavy lifting of contraction. Now, lining the very inside of these chambers is the endocardium. Normally, it's perfectly smooth, letting blood just glide right over it. But if it becomes inflamed, a condition we call endocarditis, it turns rough and abrasive. And that's bad news, because it can dangerously trigger a blood clot or a thrombus right inside the heart itself.
So, the absolutely crucial point here is understanding valve pathology. Why? Because as future surgical techs, repairing or replacing these structures is going to be a massive part of your day-to-day job. The heart relies on 4 valves to ensure one-way blood flow, but sometimes they fail. Let's contrast 2 major issues you'll see. Over on the left, we have a stenosed valve. It's abnormally narrowed and rigidly restricts blood flow, like a door that just won't open all the way. Then on the right, we have an incompetent or leaking valve. Specifically, this is a mitral valve prolapse. Here, the valve edges actually bulge and extend backward into the left atrium during ventricular contraction. That allows the blood to just wash backward, completely defeating the purpose of the one-way system.
Moving right along to Section 3, tracing the blood flow, the pulmonary and systemic circuits.
Now that we know the architecture of the rooms and the doors, let's trace the dynamic one-way flow of blood through this incredible double pump system. Listen, this sequential, 6-step journey is the absolute bedrock of cardiovascular physiology. You literally have to know this cold. Ready? First, deoxygenated venous blood enters the right atrium from the superior and inferior vena cavae. Second, it drops through the tricuspid valve straight into the right ventricle. Third, the right ventricle pumps it through the pulmonary semilunar valve into the pulmonary artery and out to the lungs. Okay, now it gets oxygenated. Step 4, it returns via the pulmonary veins directly to the left atrium. Step 5, it drops through the bicuspid or mitral valve into the massive left ventricle. And finally, step 6, that left ventricle powerfully ejects the blood through the aortic valve and into the aorta to feed the entire body. So it's essentially two independent pumps working together, a right-sided pulmonary circuit and a left-sided systemic circuit.
And this visual perfectly captures the ultimate goal of all that continuous flow. At the end of the day, it's all about the exchange happening at the capillary level. The pulmonary circuit drops off the carbon dioxide waste and picks up fresh oxygen from the lungs. Then the systemic circuit rushes that beautifully oxygenated blood out to the tissues, the brain, the kidneys, the skeletal muscles, dropping off that vital oxygen and picking up the waste to start the whole shebang all over again.
That brings us to Section 4, coronary circulation and CABG, feeding the heart muscle.
Here's the thing though. The heart cannot survive on the blood that's just pumping inside its chambers. The myocardium actually needs its very own blood supply, and arguably the biggest surgical hotspot you're going to encounter is right on the surface of the heart. The right and left coronary arteries wrap around the outside to deliver oxygen directly to the working myocardium. Now, if these vessels get blocked by a blood clot or atherosclerosis, that buildup of lipids and plaque, the heart cells literally start to die. That results in a myocardial infarction, commonly known as a heart attack. This whole disease process is driven by non-modifiable risk factors, like age, biological sex, and family history, but it's also heavily driven by modifiable factors. The classic SAD diet, which is loaded with high saturated fats, excess sugars, and low fiber, is a massive, massive driver of this plaque builder.
So what happens when atherosclerosis severely restricts that flow and chest pain, or angina pectoris, sets in? Well, surgical intervention is required. Enter the CABG, coronary artery bypass grafting. This is going to be one of the most vital bread-and-butter procedures you'll ever assist with in the OR. The surgical team will harvest a healthy vessel. Very often they'll take the saphenous vein from the leg, the radial artery from the arm, or the internal mammary artery from the chest, and they'll graft it directly onto the heart. They sew one end above the blockage and the other end below it. It creates a literal detour, a brand new path to restore that life-saving oxygen to the starved myocardium.
All right, our final stop. Section 5, the electrical conduction system. Wiring the pump.
Okay, so we've got the plumbing, we have the mechanical valves, but what actually tells the muscle to squeeze in the first place? For that, we have to look at the internal wiring. The heart has these highly specialized structures that generate and transmit electrical impulses to coordinate every single muscular contraction. It all kicks off at the SA node, the sinoatrial node, which is located right up in the wall of the right atrium. Think of this as the heart's natural pacemaker. It fires off a signal that sweeps through the atria, travels down into the AV node, goes right through the bundle of His in the septum, and finally branches out into the Purkinje fibers deep in the ventricular walls. This specific pathway is what ensures a unified, highly coordinated heartbeat. First the atria squeeze, and then the ventricles.
Now, these tiny electrical impulses traveling through the heart's wiring, they can actually be picked up on the surface of the skin using an electrocardiograph, which gives us an ECG tracing. Cardiologists and surgical teams rely on those P, Q, RS, and T waves to instantly spot life-threatening dysrhythmias. You can clearly see the difference here between a nice, normal, steady rhythm and dangerous abnormalities. Things like bradycardia, where the heart beats way too slow, or tachycardia, where it beats too fast, or even a complete heart block, where the electrical signal just simply stops halfway down the path.
But honestly, the most immediate threat you'll ever encounter in the OR is fibrillation. During normal sinus rhythm, the heart is effectively alternating between systole, which is contraction, and diastole, which is relaxation. Blood is being pumped beautifully and efficiently. But during fibrillation, the cardiac muscle fibers fall completely out of step. They're just quivering uselessly. In ventricular fibrillation, there is literally zero effective pumping action, which means blood flow to vital tissues stops completely. This is a full-blown lethal emergency. It requires immediate defibrillation, applying a strong electrical shock from an AED to forcefully reset all those scattered cardiac fibers so they can fall back into a normal rhythm. Sometimes, though, the muscle has just suffered way too many infarctions, or the valves are completely beyond repair, or the conduction system just fails entirely. When that happens, the patient is facing intractable heart failure. Either the right or left side simply cannot pump enough blood to sustain life anymore. When all other medical and surgical options are officially exhausted, the final incredible surgical resort is total replacement. As a surgical tech, you might actually find yourself prepping a cooler to receive a living donor heart for transplantation, or maybe even scrubbing in to help implant a completely artificial mechanical heart.
From understanding the tough outer pericardial sac,
down to the microscopic electrical impulses of the Purkinje fibers. Your grasp of this anatomy is exactly what's going to make you an absolute rock star and an invaluable asset in the operating room. So, I want to leave you with a fascinating thought to chew on before your next clinical rotation. As technology, mechanical implants, and surgical techniques continue to advance at just a breakneck pace, what seemingly impossible cardiovascular repairs will you be assisting with in the very near future? Thank you so much for joining me for this explainer. Keep studying that anatomy, and I'll see you next time.